So a very warm good morning to one and all present here today on a Sunday morning. Today we are going to speak on colorectal cancer screening and the treatments available now. And today we are so happy to associate with GEM Hospital Chennai. And a special thanks to Dr. Ashokan sir for helping us in coordinating for such a wonderful awareness program on colorectal cancer and treatment. Today we have eminent speaker Dr. Pinak Das Gupta, who has been working on colorectal initiatives, robotic surgeries with GEM Hospital for quite some time now. We are so honored to have you on board, Doctor. Let's start the session now. Over to you, Doctor.
Thank you, Soumya, and welcome everyone. Thanks for sparing your Sunday and learning something which is very important. And this program is all about awareness of colorectal cancer. March month is celebrated as rather I won't say celebrated. It is a sort of an awareness month for colorectal cancers all over the world. We have also done some screening programs during March month. So today, this morning, we'll be discussing regarding the awareness and how do we come to know how colorectal cancer, what is the disease burden, why it is important, because there is increasing frequency of this disease in our country as well as world over. So what you can't ignore is what I will let you know in this lecture. So just before I start, what is cancer? We know that we have millions of cells in our body. Every day, cells are dying and they are getting regenerated in our body. So this is controlled by our DNA and specific regulators in the cell cycle. When there is a deficiency, when there is some derangement in this modulation, in this regulation of destruction and regeneration, there is uncontrolled proliferation of cell. And this uncontrolled proliferation leads to formation of a tumor. And that is what we call as cancer. Now, as I mentioned, it is the cell cycle is regulated by genes, and the death and the regeneration of cells are regulated by genes. You may question me that, then what is my role? How can I prevent? If everything is controlled by genetics, then what's the point of screening and what's the point of maintaining a lifestyle and all? So this is a very important slide. So genetics is something which loads the gun, but it is your lifestyle, like how healthy lifestyle you are maintaining and your food habit, your weight, your control of diseases. These are the things. If there is derangement in the lifestyle, it can pull the trigger and initiate the cancer. So this is a very important thing one should know. Now, why we are discussing colorectal cancer? Now, this is the third most commonest cancer. It's a huge disease burden on the world, on rather mankind. Overall, the lifetime risk of developing colorectal cancer is 1 in 23 males, and for that matter, 1 in 25 females. Expected 2 million new cases are detected each year, and 1 million dies globally from colorectal cancer. So if we can do something to diagnose it early, we all know that cancer, if diagnosed at an early stage, is curable. What are the chances? Colon cancer accounts for 1 out of every 10 cancer deaths each year. So just see how is the disease burden and what is. So if we can prevent, if we can pick up these patients at an early stage, we can prevent the number of death and reduce the mortality from this disease. Now, what is screening? So screening applies to large population. So screening is not done after the diagnosis of disease. Screening is done in asymptomatic patients like you and me who don't have any complaints. But since it is a major health problem and everyone runs the risk of having this disease, and we have effective tools which are sensitive and specific in picking up the disease at an early stage and which are readily available without much of fuss and are cost effective. So that is the reason why screening is applicable for these common diseases like breast cancer or colorectal cancer. Now, colorectal cancer has a long natural history. It doesn't grow overnight. So it gives us time for that diagnosis. So if we are vigilant and if we are regular with screening, this disease can be picked up early and even before it becomes advanced and reaches the incurable stage. We have strong evidences that screening can prevent death and screening can reduce the overall mortality in colorectal cancer. Now, what are the methods we use for screening? The commonest method, which is to prevent and detect cancer at an early stage or even before the cancer comes in, are the tests like colonoscopy and sigmoidoscopy, which are invasive because we have to insert a camera inside and check the colon. There are other lesser invasive tests like the CT colonography, wherein by a CT scan also we can do when these tests are not possible or feasible. Then there are tests which can detect when there is already cancer has come. So these tests are stool-based tests. So mostly the guaiac-based fecal occult blood test, or more commonly fecal immunochemical test, which is more sensitive and specific. Newly introduced test involves the stool DNA test. Now, this is how colonoscopy is done. It is done on a daycare basis. People are very scared that a tube will be inserted and it will be very painful or something. So I would like to say that this is done under sedation. So you are not aware. The procedure takes 20 to 30 minutes time for a vigilant endoscopist to look the entire length of colon, which may be 1.5 or 1.6 meters long. The patient is positioned laterally. We have, this is the scope inside your large intestine. So we slowly navigate through the entire length of the intestine. So intestine is not a straight path. It has various curvatures. So it needs time to pass through it, and navigation has to be gentle, and we have guides which help us navigate the entire length of colon. These are high definition 2K or 4K cameras, which help us pick up even the smallest of lesion. And we have artificial intelligence systems which help us detect small polyps, or we have even negative staining or chromoendoscopy techniques where we use a spray dye in suspected area to highlight any abnormal areas. So these are, that way any small minor abnormality can be picked up early, it can be taken up, biopsied, and the nature of the disease can be found out. So one should not be worried. The only message I want to say is that it is a safe procedure. You don't need any hospital admission. It's just you need to come prepared for it. One need to cleanse the bowel. There are liquids formulations which are given to the patient, and they take it day before. Patient has to take clear liquid diet after the preparation so that the vision inside is not impaired by presence of stool or fecal matter. And because we do it under sedation, it is painless, and within 2 hours of the procedure, patient is discharged back home. Why it is important? Because 9 out of 10 cases diagnosed in early stage survive more than 5 years or even more. But if it is diagnosed in late stages, stage 4 disease, maybe only 1 out of 10 will make it more than 5 years. So if you are touching 50 or you have a family history, it is always advisable to do a colonoscopy screening, even if you don't have any symptoms. Now coming to polyps, from which the cancer can develop. The polyps are small finger-like outgrowths in the intestine, which can be the colon or rectum. There are two types of polyp. One has a stalk, which is polypoidal, or sessile lesion, which is flat and lies close to the intestinal wall. Now, this flat lesion has the tendency to progress early. If the polyps has stalk, it can be easily cut out, and these are less riskier. But the flat or the sessile polyps are more dangerous. And this can be easily picked up during a colonoscopy. And found out, they are resected, they are taken out endoscopically without any major surgery, and then are subjected to biopsy to find out whether they are harboring any malignancy. Sometimes a small portion of the polyp may harbor malignancy or cancer. So what happens is these are abnormal cells which grow slowly over time. Most of these polyps are benign. They are not dangerous. But sometimes when the size grows more than a centimeter, and if they are not taken out over the next 10, 15, 20 years, these may turn cancerous. So this is the reason why we advise polypectomy. Polypectomy means removal of these polyps and subject them to biopsy to find out if they are harboring any malignancy. So this is how it looks like, small finger-like projection from the inner wall of the intestine. This can be easily picked up during colonoscopy and resected endoscopically without need for any surgery. Now, how this changes, how it happens. This polyp can be various types, of which one type, which is known as the Adenomatous type, can slowly progress into cancer. So you appreciate there is a small polyp-like lesion. Over time, it grows. When it grows, it can spread to the adjacent blood vessel and the lymphatic system, the green glowing nodules, which are the lymph nodes, which lie adjacent to the intestine. If it spreads to them through these systems, through the blood vessel, through the lymphatic system, it spread to the other organ. So this is how the cancer spreads from a local lesion. It can spread to the liver, lungs, or anywhere in the body through this lymphatic or the blood vessel. Now, if you see the other picture, we have cancer. We all know that there are 4 stages. So stage 0 is a polyp without any cancer. Stage 1 is when it is limited to the innermost layer of the intestine. Suppose the growth has enlarged and gone into the muscle wall. This is when we label it as stage 2. Suppose from there it has spread to the adjacent lymph nodes, then it is stage 3. And from their lymph nodes, if it has spread to the distant organs like the liver or the lungs, this is stage 4 of the disease. So we don't want to go to that stage. Colonoscopy can detect it either in stage 0, 1, 2. So all those 0, 1, 2 stages, 0 and 1 stage can be managed endoscopically as well. But for stage 2, stage 3, otherwise you need surgical removal. Now coming to once the cancer sets in, what happens? The tumor grows and then there is ulceration in the tumor because the body is unable to feed it. So some part of the tumor get necrosed out of blood supply, or it proliferates in such a high speed that it doesn't get enough amount of blood supply and it ulcerates. There small ulcer sets in, and from there the bleeding starts. So these are with the slightest of bleeding, which is not visible to the naked eye. So these are occult blood. Occult means something which is not visible. So small amount of occult blood can pass in the stool from these ulcers. So of the multiple tests available, the third test, which is the FIT test or the fecal immunochemical test, is one which is the most sensitive and specific test. So it is a little bit costlier and not readily available. Other guaiac-based tests are cheaper and readily available, but needs some kind of dietary adjustments before we undertake such test. FIT is specific and doesn't need any dietary adjustment. So if you look at the guac-based FOBT, which is readily available in most of the diagnostic center, it can detect the presence of blood in stool, which is not visible to the naked eye. But vitamin C, if you take some food which is rich in vitamin C, it may give a false negative result. Though aspirin, NSAIDs, or regular diet do not have much of influence in the newer generation of Occult 2 FOBT tests, if done annually, it can reduce the colorectal cancer mortality by 32%. See how a simple test is so important and can be preventing the deaths from colorectal cancer. Now, fecal immunochemical test is a little bit more advanced. It is specific. It will detect human globulins, which is because blood is hemoglobin. So heme plus globin. So that globin part of the blood is detected by this test. It is more specific, and it doesn't need any dietary modification or dietary restriction or restriction of certain medicines. So this is nowadays coming up and more commonly being used because of increased sensitivity and specificity. Asymptomatic patient, if your FIT is positive but your colonoscopy is negative, you don't need any further investigation. But if you have a FIT positive, it's a definite indication for colonoscopy. Stool-based DNA tests are coming up. These detects some mutations and genetic things in the stool along with FIT. So they are not that standalone test, and it is combined with the FIT test. So if combined with FIT test, it is seen to increase the sensitivity and specificity of the tests. Now we'll move on to the risk categories. Like you'll ask me what risk do I have? So we categorize into average risk, increased risk, and high risk patients. Average risk is anyone who is touching 50 years of age. You don't need to be having any polyp or tumor, or you don't need a relative to quantify as an average risk. So anyone who is closing 50 or above 50 is the average risk patient. High risk patient, if you have a history of cancer in your colon, or any of your relatives, your father, mother, brother, sister, anyone has a colorectal cancer, you belong to the increased risk category. Or if you have been diagnosed with adenoma type of polyp. High risk individuals these are mostly genetic related. It can be hereditary non-polyposis colorectal cancer or polyposis syndromes like the familial adenomatous polyposis, wherein even by age of 10, 12, 20, there will be gross, the colon will be studded with polyps, and these people run high risk of developing malignancy. So if there is a family history of HNPCC or FFP, these kind of patients are offered surgery straight away even before the cancer sets in, because these are high risk category. Similarly, someone having inflammatory bowel disease, which can be ulcerative disease or ulcerative colitis or Crohn's colitis, runs the risk of developing cancer in the next 10-20 years. So they also need a regular screening, and if any suspicion is there, surgery is offered to these patients. So what are the risk factors? If we saw that there's a genetic susceptibility there, if there's a family history, then definitely there is an increased risk. Obesity is considered to be one of the very important risk factors. Certain kind of race, like African Americans, they have found that they are more susceptible to colorectal cancer, and that's why screening for them starts at the age of 45 years. Even many studies from the Asian countries have shown that the Asians also have a little bit higher tendency of having colorectal malignancies. And many of the Asian guidelines suggest screening to be started not from 50, but from as early as 45 years of age. Similarly, if you have a history of inflammatory bowel disease, that is ulcerative colitis or Crohn's colitis, or you are suffering from long-term type 2 diabetes. These are all risk factors. Certain risk factors which you have in your hand, drinking and smoking is associated with increased risk. High consumption of red meat is associated with increased risk. Fried food, over fried food, oily food, food with artificial sweeteners, and packaged food, uh, uh, the stored food, refrigerated food, they have shown that increased consumption of these kind of foods leads to higher incidence of colorectal cancer. Certain other risk factors, like if you had a transplant and you were under immunosuppression, it increases the risk. If you are taking some androgen depletion therapy, or if there is some surgery like anastomosis, the joining of the urinary passage with the colon, which is needed in certain kind of conditions. If there is history of radiation or prolonged diabetes and insulin resistance also has been linked to higher risk of colon cancer. Now, when to start screening in an average risk person like you and me? The American College of Gastroenterology recommends it at 50 years of age, we discussed. But if certain, like African Americans, they have advised the screening to be started at 45 years. Similarly, certain Asian guidelines also recommend starting it at the age of 45 years. So what are the tests we do? So this FIT test done every 2 years and colonoscopy every 10 years is the ideal test. We can, if there is no, once you have done the scopy and if there is no risk factor, we can even do a sigmoidoscopy, because most of the tumors are located on the left side of the colon. So sigmoidoscopy is limited to approximately the 60 centimeter of the distal part of our large intestine. When to discontinue screening? So suppose you have reached 75 years of age or your life expectancy is not beyond 10 years, that is the time when we stop screening. So you start at the age of 50 or 45 and then stop it by the age of 75. If you ask what is the preferred test, it is colonoscopy every 10 years and annual or at least 2 yearly fecal immunochemical test or the FIT test. Now, if you belong to the increased risk category with a family history or yourself having been diagnosed with an adenoma or carcinoma previously, then you have to get it done more frequently. For an average risk patient, colonoscopy every 10 years, and if it is diagnosed less than, if your relatives have been diagnosed less than 60 years of age, then it is recommended to have the colonoscopy every 5 years. Start the colonoscopy 10 years before your youngest relative was diagnosed of cancer. Suppose your father was diagnosed of cancer at the age of 50, then you have to start the screening colonoscopy 10 years before, that is 40 years of age. Again, emphasis about what can you do? Well, have a healthy diet, increase fiber content, decrease fat content, increase the amount of greens, have fresh fruits and vegetables, limit your body mass index within the normal 18 to 25, increase your physical activity, avoid sedentary lifestyle, avoid smoking and alcohol. Limit intake of red meat, processed meat, artificial sweeteners, again emphasis on body weight, avoid a sedentary lifestyle, and limit your alcohol consumption. Some protective factors have been lately introduced. Aspirin has shown to decrease the colon cancer and prevent recurrence Suppose you have undergone a colonoscopy and you have been diagnosed with an adenoma, there is no cancer. A certain fraction of population have shown that it decreases the progression from adenoma to carcinoma. But the one important factor is that it has to be taken for at least 5 to 10 years to have a protective effect. Though we don't have any level 1 evidence suggesting that it is definite and it is 100% protective, but we have indications that yeah, long-term aspirin may be protective. Similarly, we have evidences like calcium, vitamin D, diet with high fiber content, and low-fat diet have protective role. As I mentioned, March every month we conduct awareness program and spread awareness regarding this disease, which, if diagnosed at an early stage by the various screening methods and protocol I just emphasized, can prevent the mortality associated with this disease. Now, one important question is, how do I diagnose? How do I come to know? So one problem with this type of cancers are, in the initial stages, there are hardly any symptoms. But little bit later on, there will be some red flag signs. We call it red flag signs. And one has to be very aware of these red flag signs. Like if you have a change in your bowel habit. So you had a regular once or twice bowel movement. Suddenly for past 2 months, or you are noticing that there is an increase in your frequency, or there is a change in the caliber of your stool, or there is change, you have sudden constipation and then sudden diarrhea. So if you notice this kind of change, you should be suspicious. If there is anemia, that is low hemoglobin. Now we have come across several patients who come to us after blood transfusion for low hemoglobin. They have hemoglobin of 6, 5. They have received 2, 3, 4 blood transfusion in the past 6 months. But no one bothered to diagnose what is exactly the reason. So these patients have been bleeding from those tumors. So if I draw anecdote, it is like if you have kept an open tap and you are filling the tank from above, but since the tap is open, obviously you will keep on losing the water. So similarly, if the ulcer is there, patient keeps losing blood, and then even if you give blood, it will just raise the hemoglobin for a week or so, and slowly it will be lost in the stool. A feeling of incomplete evacuation is one more important red flag sign. What happens is there is a tumor in the rectum. Rectum is the part where stool is stored. So normally, once you pass the motion, you have a sense of like a complete relief. And if there is a tumor lying there, it is attached to the wall. So you cannot pass out the tumor. The tumor will stay back there. But the rectum will keep signaling the brain that something is there, and the brain will keep signals that you continuously have that feeling of passing. But you go to the loo and you don't pass anything, or you pass small amount of blood and mucus. So this is one important red flag sign. Rectal bleeding. Most frequently, rectal bleedings are benign from piles or hemorrhoids or fissures, but one should be aware that it can be from, if it is a painless bleeding, it can be from a cancer sitting up. Many times people have ignored this red flag sign of rectal bleeding, thinking it to be a harmless piles or hemorrhoids. But later on, at a later stage, they came and it was diagnosed as cancer. So this red flag sign again should not be ignored. Unintended weight loss. Suppose you are losing over the last 6 months, you have lost 10 kg weight, and that is totally unintended. You have had your food, or you have lack of appetite, lack of energy, feeling of weakness, and you are losing weight without any other signs. That also becomes a red flag sign. Then minor category of patient complaints of cramps and pains, weakness and fatigue. So we should not be ignoring all these important red flag signs. This is a very important slide. Again, just the emphasis that since early stage colorectal cancer really doesn't cause any symptoms, that's why receiving a routine screening is so important. And any symptoms like blood in stool or change in the shape of stool or change in the bowel pattern, unintended weight loss are all red flag signs. How do we detect? Now, once you have any of these red flag signs, you should visit your doctor. And the doctor should do a physical examination, check, do a colorectal examination, put a finger inside the rectum, because that is where most of the lesion, 60% of the lesion can be picked up just by doing a simple digital rectal examination without needing any other fancy investigation. But if nothing is found there, then other tests are asked for. Like if we don't see, if there is an anemia and we don't see blood in stool, then we go for an occult blood test like that, FIT test or FOBT test to diagnose if there is some invisible blood lost in stool. Similarly, the next step is a colonoscopy to identify the lesion from which the bleeding is happening or any other pathology lying inside the intestine. And if any pathology is found, it is further investigated with the CT scan or MRI, depending on the location. And if any suspicion, we do further test in the form of PET scan to see whether the disease is locally, it is limited to locally, or it has spread systematically to other organs. So that is where PET-CT is indicated. PET-CT is not a routine test. We don't do it on a regular basis for diagnosis. It is only if we suspect that the tumor has spread from the local to other areas like the liver or lungs. That is when we advise PET-CT. Now, if we look at the treatment protocols, as I mentioned, if it's a stage 1 or stage 2 disease, mostly surgery is enough. Surgery will take care, because in stage 1 and stage 2, we have seen that it is a local disease. It has not spread anywhere. Stage 3 disease, also surgery, along with some other therapies like chemotherapy or at times radiation, depending on the location of the tumor, is done. And targeted therapy is basically done only when the disease has spread beyond local control and it is there in the liver or lungs or elsewhere in the body. No, the same thing, if it is stage 1 and stage 2 surgery alone suffice, you don't need radiation, you don't need chemotherapy. But if it's a stage 3 disease, sometimes we do downstage the disease. So this neoadjuvant use of chemotherapy and radiation is basically done to downstage the disease. And then surgery is given. And depending on the final pathology, we again restage the disease. And if we find that there is presence of cancer cells outside the lumen of the intestine into the lymph nodes or blood vessels, then adjuvant therapy in the form of injectable chemotherapy is given. In stage 4 disease, if the diagnosis is made in stage 4 disease, which we don't want to diagnose because it is the last stage of the disease, it is advanced stage and is associated with poor prognosis, poor long-term survival. But still, with advent of newer chemotherapy or targeted therapy, we can downstage the disease. And if we are successful in downstaging the disease with all the other modalities, surgery can be offered to further control the disease and increase the overall survival. Now, coming to surgery, which is the best way to treat cancer, because you are taking away the disease from the body and limiting its spread. So age-old practice is open surgery. We have done open surgery for last hundreds of years. And then slowly over the last 30 years, we have moved to laparoscopy. Laparoscopy surgery gradually got refined over this last 30 years. And we have all the new technology and the augmented vision system, wherein we have the 2K system or the 4K system, wherein you get the best of quality of vision so that you can do high quality surgery. Further modification has come over the last 10 years, which is robotic surgery. Again, this gives us more precise surgery, and robotic surgery is also a form of minimal invasive surgery. And more being used for rectal cancers. Now, why do we choose laparoscopic surgery or minimal invasive surgery? So these minimal invasive surgeries are no inferior. It has been proven in multiple studies. Initially, there was a skepticism attached to it that whether it's a cancer surgery, it will need a radical surgery, whether can it be done laparoscopically? Can it be done adequately with small holes? But now we have multiple studies which have shown us that yes, it can be equally radical done laparoscopically. It gives the benefit of small incision, a very small scar, less pain. So small incision is associated with less chance of wound infection and wound-related morbidity. Finally, if you have less pain, you are mobilized early, you start your diet early, you are discharged sooner from the hospital, leading to a shorter hospital stay, faster recovery, your immune functions are preserved, and even if any further chemotherapy is needed, it can be started early. So all these are the advantages of minimal invasive surgery. Again, robotic surgery is also a form of minimal invasive surgery. Many patients ask me, what exactly is robotic surgery? And is it that the robot is going to do the surgery? If the robot is going to do the surgery, what exactly you are going to do? So it is not something which the robot does or the automation industry we show in auto industries. This is where we sit and operate. This is called the surgeon console. So it is not that the robot is autonomous, it is controlled by our hands. The instruments are mounted on these robotic arms. And this is my hand movement, which is reproduced inside by the robotic arms. The advantage is that there is no shaking of the instrument, there is no tremor. The instruments are very sturdy and very steady. There is high magnification. Magnification can go as high as 25 times. So every minute details will be magnified and projected to our eyes. It has a binocular vision. So it gives a 3D vision. So once we sit in the console and operate, we have a sense of what is called immersion. We feel as if we are sitting inside the abdomen of the patient and operating. So that immersive vision, because of the three-dimensional vision, gives the surgeon that advantage of high magnification, minute details comes up, and it can be done in a more precise way. More so when the area is very confined. Like in rectal cancer, we have to work in the narrow confines of the pelvis. The rectum is bounded by bony things. We cannot distend the bony things. So when we are working around a very narrow space, the robot gives us a very good advantage because of increased degree of freedom. Our hand movements are limited, but since the robotic arms have a free range of movement, manipulating these instruments in a narrow confined field gives us a lot of advantage. So what is the benefit of robotic surgery for patient? It is more precise, less pain, fewer complications because it is done in a more precise way. It reduces the number of hospital days, and the overall recovery time is small. For surgeon like us, because it gives us an enhanced vision, sense of immersion in the field of surgery, magnified vision, three-dimensional vision, the surgery becomes more precise. The instruments are more dexterous, by, which means that it can be articulated in a various direction and various angles to carry out the surgery more precisely. And since cancer surgeries are tiring, it's a long duration surgery. Sometimes surgery extends 7, 8 long hours. And if you are standing and doing it for 7, 8 hours, however fit you are, at the end of it, you will feel tired. In robotic surgery, we sit in the console and operate. So you don't feel that tired as compared to open microscopic surgery. Now coming to chemotherapy, since surgery addresses the local disease, and we know that cancer tend to spread. So what chemotherapy does is, if this cancer cell from the tumor spreads out to this lymphatic or blood vessel and settles in some other place and starts to grow there, the cancer cells are highly proliferative. They reproduce very fast. So this chemotherapeutic agent targets these fast growing cells. So they will find out wherever the cells are growing fast, go and get attached there, and gradually destroy those cells and shrink the tumor. And since it is given through the blood vessel, it spread out through the entire body. And wherever these highly rapidly growing tumor cells are there, they go and get attached and destroy these cells. This is how chemotherapy works. Now coming to radiation. Now, radiation is given, suppose the tumor is very big and bulky tumor. So we want to shrink the size of the tumor. So what radiation does is it shrinks the tumor so that it becomes capable for us to take it out without damaging the surface of the tumor. Now, one very important part of surgical treatment of cancer is that it has to be taken out without touching the cancer cells. So there should be a cancer-free margin surrounding the tumor. Our resection margin should not have any cancer cell. So if the tumor is very big and touching some nearby organ, so it becomes difficult for us to take out the nearby organ, or it increases the complexity of the surgery. So in those kind of scenario, we radiate the tumor, which cause destruction of the cell. And suppose the tumor was 10 centimeter in size, and after radiation, it becomes 5 centimeters. It becomes more manageable to handle such tumors. So this is where radiation plays a very vital role. So in radiation therapy, this patient is placed inside the scanner, and the tumor is identified, and these targeted radiation therapies are given. So exactly, radiation beams are focused on the tumors. There are various types of strategy like short course or long course, depending on the type of the tumor, the bulkiness of the tumor, stage of the disease, and surgeon preference. So this radiation basically downstages the size of the tumor and allows us to do what we call a R0 resection, or a resection without no cancer cells on the margin of the resected specimen. Now, done with surgery, sometimes we have to do a stoma. So what is a stoma? These patients are very much worried about stoma. So stoma is an opening in the abdomen, which basically connects your digestive system to allow the stool or waste material to come out of your body. So when we do such major surgeries, that part of the intestine is taken out, and then we rejoin the intestine. So if now with latest technologies, we are avoiding more and more stomas, but rare circumstances, we do need to have stomas, more so if the patient presents in an emergency situation where we don't have much time to evaluate the disease. So many times after the surgery, we do what is called an ileostomy, wherein the small intestine, an incision is given in the abdomen, and the small intestine is taken out and placed in the abdominal wall. It is stitched to the abdominal wall. Now what happens is, this will allow the, the resected part to heal, and at the same time, the whatever waste material is coming out comes out in this ostomy site. So we place a bag. This is a ostomy bag which attaches to the stoma and has to be emptied on and off whenever it is filled up. So this allows the resected part to heal. The important things are stoma is easily, it is concealable. These bags doesn't leave any odor. It fits securely so that you can maintain your normal physical activity. These are easy to maintain. Patient can himself or herself apply the stoma bag. It has to be emptied several times because number of times whenever you eat, there will be some amount of discharge. But the one important thing is that anyone with stoma can lead a healthy life. He can go for swimming, cycling, running, and can have intimate relationships. Similarly, there is something called colostomy. So colostomy is done in the colon. Ileostomy is done in the small intestine. So colostomy can be an end-loop colostomy when it is done in the lower part of the large intestine. It can be in the transverse part of the large intestine where it is done as a loop colostomy. Or sometimes after resection, we bring out the stoma as an end stoma. Or in those lower rectal cancers or anal cancers where we cannot spare the anal sphincters, stoma is permanent. But with advancing technology, we have very limited patients who are subjected to permanent stoma. So one should not be very disheartened that if the doctor suggests that you need a stoma, because most of the time there are stoma nurses and trainings and stoma support group wherein easily you can easily you can manage the stoma. So these bags comes and a patient himself or herself can easily place this bag, replace this bag, and enjoy a healthy lifestyle. Is stoma avoidable? Yes, it is possible. We at GEM Hospital are relentlessly trying and using best of technologies and techniques so that we can avoid stomas in most of our surgeries. So what strategies do we take? So the reason why stoma is indicated in some patients, suppose if we cannot spare the sphincter, the anal valves, which regulate the motion, then there will be continuous seepage of motion if we keep the colon right at the region of the anus, if we cannot spare the sphincters. So that is the reason to make it more manageable. We place it on the left side of the abdomen and it is managed with bags. But more and more we are trying to do sphincter sparing surgeries. Usage of radiation, chemotherapy allows to shrink the tumor and allows us to spare the sphincters. Use of stapling devices and robotic technology or TransAnal surgery, allowing us to do ultra-low anastomosis or called the coloanal anastomosis, and allowing us to prevent stoma in many of the cases. But rarely, definitely, stoma is needed. So you should cooperate with your doctor. You should not be very adamant that we don't need stoma, because most of the time it will be a temporary one and will be closed within a span of 6 to 8 weeks. Or if you need a chemotherapy, we complete the chemotherapy and then we close the stoma. So these are the various techniques which I was mentioning. TransAnal surgery has come up so that we need a margin-free tumor resection. So if we cut the tumor using this technology, we can clearly have a margin of resection will be devoid of cancer cells. Then using robotic technology, we can go very deep inside the pelvis and prevent, do a nice anastomosis and prevent stoma. use of stapling technology. These are powered stapling technology, which allows us to create anastomosis at a very low level and allow us to avoid stomas. There are many famous personalities living with stoma, and they are carrying with their normal regular day-to-day work without hampering their normal work and their normal profession. So one should not be upset that they have stoma, because there are great achievers who have stoma. So this is all. Thank you, and thanks for joining us for this awareness program. I hope this was useful, and I'll be happy to answer questions which have cropped up in the chat box. Thank you.
Thank you, Doctor. Indeed, it was a detailed presentation for maybe understandable by both doctors and also the common people who have joined the sessions today. We have a couple of questions that we already got. So can I start the questions to you right now?
Yeah. Please.
Yeah. The first question is, what was the first symptom for colon cancer?
That if you ask me, first symptoms are always late. So that is the reason we emphasized on screening, because symptoms in cancer and most of the cancer are late to start. So this is one very important point everyone has to note. There are no early symptoms, but if the cancer is suppose situated in the last part of your large intestine, most often patient will come with bleeding of rectum. Again, people ignore it. They think that bleeding rectum is most often piles. Yeah, it is most often piles, but it can be cancer. And actually, there are several instances we have found very learned people, highly educated people coming to us, ignoring the symptom of bleeding per rectum. They thought that it is piles. Their friends told that it is piles. But because of COVID and all, they didn't turn up. And on examination, we could see that the disease is advanced and they have lost the opportunity of early detection and complete cure. So this is the most important message we want to say. And the common symptoms are definitely passage of blood, sense of incomplete evacuation, low hemoglobin level, unintended blood loss, fatigue, change in bowel habit. These are the red flag signs which I mentioned.
Thank you, doctor. So the next question is, okay, this is a patient-centric question asked by Ms. Varsha. My paternal grandmother was diagnosed with colon cancer at the age of 75. Do my father and I carry the genes, and do we need to screen ourselves?
See, definitely, even if we ignore that history, anyone at more than 50 should undergo a screening. So paternal grandfather gene definitely can come down through your mother to you, not your father. And that becomes a second degree relative. Means first degree is your own mother, father, brother, sister. Second degree is their parents or their mother's side. So definitely, if that he or she was diagnosed of cancer before 60 years of age, definitely there is the screening becomes more important. But if the diagnosis is at the age of 75 or something, that is we call as sporadic cancer that can happen with anyone, and that doesn't place you at a higher risk as such.
Thank you, doctor. The next question is, how much the tumor markers help in diagnosis of the condition?
Tumor markers in colon cancer is one of the commonest tumor marker used is carcinoembryonic antigen, or the CEA. It is not used as a screening test. It is only increased when you already have a tumor. So I emphasize that screening is not for person who has developed a cancer. Screening is only for those person who may develop and have the risk of developing. So cancer markers are only used in the follow-up after therapy for cancer. You have underwent a surgery, you underwent chemotherapy, radiotherapy, whatever therapy is over. Then we, every 3 months for the initial 1 year, we see the carcinomembranous antigen level. Any sudden increase in the level from the previous this thing will give us a sign that there may be some recurrence. So that way the markers are used. It is not used as a screening tool.
Okay, doctor, thank you. The next question is, doctor, what is the difference between colon and rectal cancer?
Okay, so colon cancer, rectum is the last 15 centimeter of our large intestine. Rest of the large intestine is colon. Rectal cancer is more common than colon cancer. Rectal cancers are a little bit more aggressive, and rectal cancers have, that's what rectal cancers will be more aggressive. And if I compare between colon and rectal cancer, so overall survival of colon is better than rectal cancer. Rectal cancers will present more often with fresh bleeding and all the red flag signs. Colon cancer presentations are more of like anemia, weight loss, those kind of presentation.
Thank you, doctor. The next question is, recently diagnosed with appendix. Do I have to worry about it, doctor?
No, as such, there is no correlation, but there are few studies which have shown that post-appendicectomy, the incidence of colon cancer is more. So if you've had an appendicectomy done for appendicitis, then maybe that screening becomes more important to you. So there is no direct correlation as such. But yeah, you consider yourself as an average risk patient and do the routine screening starting at the age of at least 50 years of age.
Thank you, doctor. The next question is, how does colon cancer usually progress?
Yeah, so I have shown a video wherein you can see, it takes time. It doesn't happen overnight. Sometimes it can start de novo, means directly one of the cell becomes cancerous and then slowly it progresses, which is less common. More common is adenoma carcinoma sequence, wherein you develop a small polyp, which on biopsy turns out to be an adenoma. This adenoma, usually in a no risk individual, will slowly progress in the next 15 to 20 years to develop a cancer. But if we have this lifestyle triggers, or if we have some genetic triggers, this 15 to 20 years duration may be reduced to 2 to 5 years. So in presence of trigger factor, it can progress in 2 to 5 years. In absence of that, it may take up to 20 years to progress from a small 1 millimeter, 2 millimeter lesion to a large cancer. Now, progression, like as I said, it is usually slow, but within 2 years, once the tumor develops, once there is presence of cancer cell, the progression starts rapidly. So from an adenoma to a carcinoma, it takes quite some time. But once carcinoma sets in, it will be rapid progression. And if our intestine is a lumen, so it is 360 degrees. So it takes 2 years to complete the 360 degree. So if you have been diagnosed with a tumor which is circumferential, which means it turns from one end to the other, 360 degree, that means we can have an estimate that it is there for more than 2 years.
Okay, thank you, doctor. The next question is the colorectal cancer in men and women. What are the difference?
Not much actually. Men's are a little bit more incidence than female, but in India, if we compare, more or less equal only.
Okay, doctor. We'll take the last two questions. Okay, I have a lot more coming up, but we'll take two more. Is it okay, doctor?
Fine, fine.
Yeah. The next question is regarding the CT scan. Okay. So, can a CT scan show a mass in the colon? What is your suggestion?
Yeah, definitely CTs can pick up. So if we pick a mass in the CT scan in the colon, it it is just an interpretation. So we need a diagnosis. For diagnosis, next we'll ask the patient to undergo colonoscopy. So colonoscopy through the camera, we have channels to take. We exactly visualize the lesion, where it is, how big it is, how much part of the intestine it is involved, and then we take biopsy to exactly find out what is the nature of the nature. Ulcers can be even a tubercular ulcer or an inflammatory ulcer or a cancer. So by biopsy, we come to know that whether it's a cancerous or cancerous lesion or a benign lesion.
Thank you, doctor. The next question I'm taking from the Q&A box. Uh, any studies proving the role of diet in the manifestation? What are the points to be considered for better prognosis among the diagnosed?
Diet. Yeah, so that's what has been shown that a healthy lifestyle and healthy diet. So if you are avoiding processed food, red meat, you are avoiding alcohol, you are avoiding smoking, maintaining a healthy body weight, avoiding sedentary lifestyle. So these all things, along with certain vitamins like vitamin C, vitamin D, calcium, omega-3 fatty acids, which are readily available in fish. So fresh fish. So all these things have shown protective role. So all these food materials will prevent the DNA damage, which initiates the cancer. So this will prevent triggering of the genetic alterations which needs for development of cancer. So it is proven beyond doubt that if we maintain a healthy lifestyle, maintain a high limit of fat intake, and have a high fiber diet, fresh fruits and vegetables in our diet, include regular exercise. So these will help prevent the pulling of trigger and at least delay or prevent the progression of disease.
Thank you, doctor. We are going to take the last questions asked by Costa. Which other organs mostly commonly affected in the case of colorectal cancer, and it may cause another diseases?
So colorectal cancer, I hope the question is like from the colon where it spreads, what other organ it can spread. So the commonest organ which gets affected is the liver, because the blood supply of the colon drains into the liver, and we all know that cancer spread via the lymphatic system or the blood vessels. So via the lymphatic system, it spreads to the lymph node. So whenever a cancer has spread from the bowel to the lymph node, it becomes a stage 3 disease. When the lymph node is adjacent, because most of the lymph nodes will be adjacent to the bowel, next to the bowel. Now, if via blood, it reaches the liver and gets deposited inside the liver, then, which is the commonest site of spread, the tumor starts growing there. So when it reaches the liver or the lungs or any other organ, we label it as a stage 4 disease. So limited to the bowel, stage 2. Gone into the lymph nodes, which are adjacent to the bowel, it becomes a stage 3 disease. And gone into the other organs like liver, lung, it becomes a stage 4 disease.
Thank you, Doctor. Just one more question I wanted to add, if the time permits, is colorectal issues in senior citizens or the older age population. What is your thought on it?
So it's very important. Most of the senior people, most of the time when they have bleeding per rectum, they think that it is piles. It is true that yes, more commonly it will be something benign, but as the age goes beyond 50, beyond 60, the chances of developing cancer is higher. So one should be more and more suspicious, and one should not just live on assumptions. Rather, you go visit your doctor, get a screening, get yourself tested. If you don't have any problem, you are almost safe for the next 10 years. You can just do a simple stool test every 2 years and get yourself screened every 10 years. One colonoscopy is not a big deal. And given the benefit of that and proven thing that it can save life, it becomes very important that we emphasize screening in senior citizens, and screening is continued till the age of 75. At that point, if we are not diagnosing, means the next test will be, next colonoscopy will be scheduled for 85, which is beyond the average survival age. So that's why screening is limited to 75 years of age. But for senior citizens, yeah, anyone above 60 is at a higher risk and should mandatorily undergo a screening test.
Thank you, doctor. I think we are getting so many questions coming in. So what I'm going to do is we can take up the questions offline, or maybe we'll come back with another session in detail on certain aspects in colon cancer, the treatment, screening. And doctor, would you like to highlight a couple of the action plans that GEM hospitals have done under colorectal, so that people in and around Chennai and Coimbatore can access the services by GEM hospital? Would you like to highlight what kind of?
So the one important thing I want to highlight is like GEM Hospital is a specialized center for gastrointestinal diseases. Now, it is not only that we have specialists who is dealing in all gastrointestinal diseases. Again, we have divided. We have teams specifically dedicated for liver, pancreas problems. I am heading the colorectal department at Chennai, and I have a team of doctors. It is not my individual decision. Every patient is different. Every patient present at a different circumstance, disease presentation is different. So we have a set team of doctors, which involves we surgeons. We have 4 senior surgeons. We have radiologist, or medical oncologist, radiation oncologist. We have pathologist. We all sit together, and every patient is given an individualized care. So which is not available in any other routine hospitals. So you need dedicated doctors treating this disease, giving adequate emphasis to the problem, finding out the best suited problem for the given stage of the disease, and then following the international guidelines. So that is how GEM, it becomes special. We give individual care, and one of the important thing, we sit and discuss the patient before surgery. What are their expectations? What should be the expectation from the surgery? What will be the pre-surgery preparation, post-surgery protocol, whether they'll be needing any pre-operative therapy, whether they'll be needing any post-operative therapy. We conduct support group meeting of new patients with our previous patients, so that they can, how the life is going to be after the surgery, how exactly the surgery, how difficult. Many people are scared of surgery. Our patients, we follow a fast track procedure, fast track recovery of the patient. So these patients, most of them are back home within 4 days, 5 days from these major surgeries. So all these kind of time to time interaction, patient interaction help the patient to develop confidence and get away from the fear of the disease. We conduct regular screening camps. We encourage screening. We do it every March. The awareness program is conducted. Time to time, various promotional programs are done, so that we can pass on the benefit to all the new patients, and also our existing patients suffering any issues are readily approachable to us, through the support group meetings. So this is what we do for our patients.
Thank you, doctor. One last question. Since you head the robotic division in Gem Hospital, there are a couple of questions I've got regarding the success rate. What are the procedure Gem Hospital follows under robotic aspects? What would be the feature?
So science is continuously developing. See, technology, we cannot be, we have to update ourselves with technology. The technology becomes an integral part. We know that how artificial intelligence is progressing, man and machine. So these are not two separate entities. We have to work in collaboration. We have to help each other. So it is just an extension of minimal invasive surgery. From open surgery, we moved on to the laparoscopic surgery, seeing the multifold benefits of laparoscopic surgery. The early return, there is the overall outcome, if you say, has not changed much. Overall outcome is improving day by day. If I compare laparoscopy with robotic surgery, almost more or less equivalent benefits. But looking forward in the next 10 years, technology is going to develop on the robotic side. Technology has come to a standstill because laparoscopic surgery is 20 years old now. Now, all the innovations which are coming, all the artificial intelligence, we are incorporating CT images, MRI images into the robot, which gives us a real time when we are operating where exactly the tumor is placed. In a CT scan or an MRI which is fixed after mobilization of the organ during the surgery, where exactly is the tumor, we may miss. But with this augmented reality put into the computer, put into the robotic system, it gives us a real-time picture of where exactly the tumor is now after the mobilization. So all these things are, it's still, I will say it is still in development, and it will be development. And for a surgeon, the times have always been exciting because of technology. We keep upgrading ourselves, and with technology, we move on. Just that at this point of time, it may look a bit costlier because obviously with technology, with innovation, it comes at a cost. But then if we can pass on the benefits to our patients, definitely there is a great future ahead. And all type of surgeries, all type of complex surgeries are nowadays performed by robotics, may it be cancer surgeries of the pancreas or colon or rectum or any of the intra-abdominal or intrathoracic cancers.
Thank you, doctor. So on behalf of MedPiper Technologies, JournoMed, we would like to thank you for joining us on a Sunday morning. As I said, Sunday is a rest day, and you have joined us today for creating awareness on colorectal cancer and what are the treatments available right now, and some thoughts on lifestyle changes and diet management, so that somewhere around we will be able to cope up with the cancer and we can fight against the cancer. Thank you, Dr. Vinagda Gupta,
Thank you.